Hey, so good evening and welcome to a special Brain Matters webinar for January Alzheimer's Awareness Month. My name is Susan Oster, Public Education Coordinator with the Alzheimer's Society Southwest Partners. I will be the MC and moderator for this webinar. Sarah Sweeney, another educator with the Society, will provide technical support. At the Alzheimer's Society, our role is not only to provide programs and services for people who are going through the journey of dementia, but also to provide dementia education and to advocate for those living with cognitive disabilities. So before we start, I have a little business to go over relating to the webinar experience. Please note that your cameras are off and microphones are muted for the webinar. This event is being recorded, and the recording will be available in the future on the webinar archive page of our website. At the end of the presentation, we will have approximately 20 to 25 minutes for a moderated Q&A, and we will do our best to address as many questions as we can. During the presentation, if you think of any questions for the speakers, please add them to the Q&A box located at the bottom of your screen. So you can see there in the image. If you would like to submit a question anonymously, please click the Send Anonymously box before clicking the Send button. Should you have any technical concerns, please type in the chat box and Sarah will be happy to help you. You may need to move your cursor around to see the Zoom controls and icons. You can submit your technical questions in the chat box and they will only be seen by the panelists, which includes myself and Sarah. And we have also enabled the upvote feature in Zoom, and a little note of history. We actually learned about that feature from Dr. Borrie some time ago. Thank you, Dr. Borrie, which allows people to see all questions being asked and to move the most popular questions to the top of the list. If you see a similar question posted by someone else, you can simply vote on the question by clicking the thumbs up icon underneath the question. And once the icon is clicked, the question will move up the list. And because we have a very large attendance tonight, we really encourage people to use that feature because we want to get through as many questions. And again, we want to get to the most urgent and popular questions first. Just a little note here. So since everyone's situation is unique, the information being provided in this presentation is for educational purposes only. Should you have specific questions about your situation, please contact your healthcare provider or your support worker with the Society. And now I have the great pleasure of welcoming our presenter. Dr. Michael Borrie is a geriatrician at Parkwood Institute and a professor in the Department of Medicine, Division of Geriatric Medicine at Western University. He is the medical director for the Aging Brain and Memory Clinic, an investigator with the Cognitive Clinical Research Group, or CCRG, and past president of the Consortium for Canadian Centers for Clinical Cognitive Research. Later in the presentation and during the Q&A, we may also hear from Sarah Best, a little wave, who is the research manager for the Cognitive Clinical Trials Group at Parkwood Institute. So welcome, Dr. Borrie and Sarah. I'm going to stop sharing.
Greetings. Thank you for joining this webinar. I just want to thank Shelley Crosby on my end, who's helping to make sure that this proceeds as it should. These are my disclosures. On the left are the research support for investigator-initiated studies. On the top, you can see the clinical trials funding from the different pharmaceutical companies, and I've also participated as a consultant and been involved with continuing medical education programs to educate family physicians for different programs by the companies listed there. These are our objectives this evening, to be clear about the differences between mild cognitive impairment and dementia, and what a person affected by mild cognitive impairment or dementia or their caregiver might do. Look at the lifetime risk factors for dementia and how to modify them, to understand something about the current theories of Alzheimer's disease and the development of biomarkers to actually measure this disease, to look at some of the latest information on potential disease-modifying treatments, which currently are given intravenously. In particular, we're going to talk about lecanemab and donanemab, which you may have read about. Talk about the side effects from these intravenous antibody treatments, and also look at some of the current intervention, observational, and biomarker studies conducted at our site and in Canada. Some of you may be aware of this, having seen it in the Aging Brain and Memory Clinic, the spectrum of cognitive decline. People who are supernormal, those over the age of 80 who score the same as 20-year-olds on memory tests. People with normal age-consistent loss have no concerns about their memory and score normally on memory tests. The common one we do is the Montreal Cognitive Assessment, or MoCA, which I'll show later. The subjective cognitive decline are people who notice changes, and secondly, who are concerned about them. And they score normally 26 or better on the MoCA as well. People with mild cognitive impairment notice changes in their memory, as certainly their family members may notice it, score less than 26 out of 30 on the MoCA, and their instrumental activities of daily living are largely intact. They're not impaired. They may take longer to do some of these activities. And people with dementia certainly have cognitive impairment measured by the MoCA, or the mini mental state exam, as another cognitive measure done by specialists and by family physicians. And they have one or more of the instrumental activities of daily living significantly impaired. We need to understand what is the underlying process that is causing the shift from the left to the right, from normal through to dementia, because this just describes the functional changes in cognition. So underlying that are diseases eventually leading to dementia, but obviously starting somewhere out to the left and progressing to the right. Alzheimer's, vascular Lewy body, and frontotemporal dementia, and then some of the other causes are cognitive impairment, less commonly listed on the right. The Alzheimer's Society on their website have the 10 signs of dementia. These aren't given in any particular order in terms of the sequence, but what we're going to talk about this evening is how do we actually go earlier and identify problems before they actually get to the point where these are significant problems. So, you know, what are the earliest point that we can actually identify these change? And some of the questions that I ask of people when we see them in the Aging Brain and Memory Clinic is, when was your, speaking to the person, or your family members, speaking to the family member, memory last normal for them? When was their memory last normal? A person who has very good insight, maybe someone with subjective cognitive decline who may still be working, can identify the changes at work or with hobbies, and these may not be apparent to anyone else. And if a person has little insight and they're saying, I don't have a memory problem, it's that person there that has the problem, pointing to their family member, then the questions has to be asked of the family member alone in another room, whether that's with a specialist or with a family physician. In my experience, some of the early signs can be determined with increasing frequency over months, and the family may have observed them over years, but it's not days or weeks, this is months or years, and in that sense it's measurable. And I'm listing there a lot of things that you will be able to identify, but these are the common things that are the very early changes that you may notice. This is getting to the objective measurement that we may be able to put a number on, and this is the Montreal Cognitive Assessment on the right. It's got 8 different cognitive domains, which are labeled there on the test down the left-hand side in the black labeling. If a person themselves is aware, or if it's a family member, they may bring it to the attention of a family physician, requesting a MOCA test, and it can be repeated again in a year or two, and then you want to watch for changes in the total score. Sometimes if a person on the first test scores close to 26, either above or below, on a second time, they may do better because they've seen the test before, they remember that, the memory's sufficiently good that they can remember they had done the test before, and they may do better. But then if you see progressive decline in the total score of the various elements, then you may want to have a further assessment by a family physician or in one of the MINT memory clinics. There's about 20 in southwestern Ontario, or a specialist referral. These are the risk factors that occur during life, and if we could eliminate any one of the risk factors, you can see the percentage prevalence by which cognitive impairment would be reduced. So you can see this going throughout life, and there's a potentially modifiable risks when you add them up. It's about 40% of those risk factors are modifiable, but there's another 60% which are not known. Age is part of that. Getting old is a risk factor, but it doesn't cause dementia. There are strategies to try and reduce the likelihood of developing impairment, and if someone already has impairment, they may then be able to reduce the likelihood of progression. And so we talk about exercise, pay attention to diet, particularly the Mediterranean diet, but there are other diets that are good for brain health as well. Restorative sleep, mental stimulation. Wordle is something that people have started doing more recently as a new stimulating activity, but there's many others. Socialization, managing stress, paying attention to dental hygiene, particularly later on if a person has cognitive impairment, particularly in the long-term care. Pollution, and then alcohol reduction. The current guideline, 2 drinks a week. Many people are surprised to learn that. But if they have cognitive impairment, I encourage them not to be drinking, and there are a lot of non-alcohol options. Depression can be managed with non-drug approaches or drug treatments. And then there are 5 vascular risk factors listed there that are risk factors for stroke, need to be managed and monitored. And then hearing impairments, replacement or compensation for hearing impairment with aids may reduce the progression of cognitive impairment. And there's some evidence of that. So looking at some of these interventions, this is an observational study done over a period of 12 years. If you look at the baseline there, and you can see on the vertical axis, the reduction in probability of developing dementia. So you can see 3 cohorts, people with high physical activity and a high diet score for a Mediterranean-style diet, and the dotted line at the bottom, low physical activity and low diet score. So a difference of about maybe 75% probability versus less than 60% probability of remaining dementia-free over a number of years. This is an intervention study, and this one involved multiple domains of intervention, and this was done in Finland over 2 years. Participants 60 to age 77, and the interventions are listed there. And the control group got health advice. And then the outcome was improved cognition and reduced risk of cognitive decline in the intervention group. So this was the finger study. In London, Ontario, we had Dr. Monteiro Dasso lead a national group, 5 Canadian sites, on a multiple intervention study for people who had mild cognitive impairment. Now, the finger study I showed you in the previous slide were people at risk of cognitive impairment. These study was done in people with mild cognitive impairment, and the participant age were there, and the characteristics. And they had 5 different arms. So 4 of the arms had exercise, 1 exercise, cognitive training, and vitamin D. And then you can see the different combinations of that with sham cognitive training or placebo vitamin D, and then the control group at the bottom with toning, exercises, sham cognitive training, and placebo vitamin D. And the groups 1 and 4, which all had exercise, improved on measures of cognition, and they used the ADAS-Cog and improved regardless of the of cognitive training that was compared to the control group. Arms 1 and 2 compared to arms 3 and 4 improved as well, and arms 1 compared to arms 5 improved. And you're seeing a negative score there, and this is because the ADAS-Cog 13, which was the instrument used, goes from 0 as normal cognition to 70, which is severely impaired cognition. So an improvement on that scale, which is commonly used in cognitive trials. If you saw an improvement, you would have a lower score, and that's why it's a negative score. And this is another way of looking at that. On the left, diagram A, you can have the ADAS-Cog, and you can see that across the baseline, the 5 different arms, but it's just a graphic display showing how arms 1 and 2 did better than the other arms, and then the same across on the right in diagram B, you can see the dark green line, dark blue line, arms 1 and 2 did better than arms 3 and 4, or the control group, which got slightly worse over the course of the 6-month study. So we want to talk more about the diagnosis of Alzheimer's disease, and what we have here on the left is a representation of normal nerve cells, 3 nerve cells, and they have connections to the other nerve cells through their synapses. A nerve cell can have up to 2,000 connections with another nerve cell. We're only showing a few in this diagram. And you can see the cytoplasm, and then next to that is the image of Alzheimer's disease with the amyloid plaque being deposited in the cytoplasm, and within the nerve cells, the neurofibrillary tangles. And to the right, what these things would look like under a light microscope. If you're looking at, and this is what Alzheimer would have seen. Now, he described plaques and tangles. He didn't know it was caused by amyloid at the time. This is the hypothetical biomarker evidence of pathological change due to Alzheimer's disease. So this is a model based on biomarker evidence. And across the baseline, you can see stretching from normal through preclinical with no symptoms at all, mild cognitive impairment, and dementia. And on the vertical axis, you've got biomarker magnitude as a measure, and this is the abnormal at the top and normal. So this is rising biomarker abnormality. And the first thing that we understand changes is that the amyloid accumulation occurs in the brain, and we can measure this on cerebrospinal fluid and PET, and I will talk more about that measurement of that biomarker, those biomarkers. And then you get synaptic impairment following that, and this is the change measured using glucose PET imaging and fMRI imaging. And then over the green line is showing the tau abnormality measured in CSF. And then as you start to develop mild cognitive impairment, there may be structural changes in the brain measured using MRI, and they can show volumetric changes with shrinkage of the hippocampi, for example, the memory department of the brain. And then cognition declines as measured on cognition tests like the MoCA. And then eventually you get impairment in clinical function. Now, this is the Alzheimer's disease drug pipeline for 2023. You can first see that there are many compounds being explored, and the rings go from phase 1 to phase 2 for phase 3. These are the phases of trials with increasing complexity, but focusing always on safety and efficacy. And we're going to focus on the green segment of this diagram, in particular the phase 3. And you can see lecanemab there and donanemab, two compounds we're going to talk about. Now, biomarkers are measured, and they can measure normal processes, and they can measure disease, and they can measure the response to drug treatments. And they tell us who might be at risk of a disease, its prognosis, and they can be measured in Alzheimer's disease using positron emission tomography. And that PET is what that is shortened to. It's brain imaging, so that's the contraction, PET imaging, and cerebrospinal fluid, CSF, and it can be measured in blood. So this shows amyloid scans. These first became available in 2024. And what we know, if we look at the image on the left, is that the scan, looking at that brain, the top part of the image is the front of the brain, and the bottom part of the image is the back of the brain. And the image on the left of those two shows no amyloid or very little amyloid, and the one on the right shows a lot of amyloid. And that correlates with those plaques, with the arrows pointing to the plaques in the cytoplasm that you could see on a microscope. So we can now image, what Alzheimer could see on a microscope, we can now see on a brain scan called a PET amyloid scan. And this measures the amyloid as it's gradually deposited in the brain, and it may occur over up to 20 years before the next abnormal protein, tau protein, causes the neurofibrillary tangles and the onset of symptoms. Now, tau protein is a natural protein, but it becomes disordered. The plaque on a positive PET scan in someone who's cognitively normal, or in people with mild cognitive impairment, is associated with increased risk of dementia. So those people are more likely to develop dementia. A negative PET scan makes it very unlikely that Alzheimer's disease is present. And if a person has cognitive impairment, it may mean that they have a different disorder. It might be frontotemporal degeneration. It could be small strokes. It could be Lewy body changes. The PET scan tracer is given intravenously before the PET scan. They have a short half-life. 30 minutes was the first one, PIP, and latest ones last up to 2 hours. And it's measured on a scale. The amount of amyloid is measured on a centiloid scale from 0 to 100. So the image on the left might represent something close to 0, and the one on the right might represent something close to 100 on that scale. We can measure cerebrospinal fluid, measure amyloid in the cerebrospinal fluid, and this is done as an outpatient procedure. Another name for the lumbar puncture is the spinal tap, and it's done in a lying position, and a very fine needle is used to obtain the CSF. They use a local anesthetic. It's a bit like a epidural, not even as invasive as an epidural. And the amyloid protein comes in two lengths. The ones that we measure in particular is 42, they're 42 or 40 amino acids long. And people with Alzheimer's disease have 40 to 60% reduction of amyloid A beta 42 concentration in the cerebrospinal fluid. So the amyloid, the way I think of this is the amyloid is decreasing in the cerebrospinal fluid as it's been deposited in the brain. And there's a ratio that we can measure, the A beta 42 to 40 ratio, and it's reduced and is even more accurate than just measuring the A beta 42. And these measurements in CSF in people with mild cognitive impairment, if they're present, and they're decreasing, it shows the future development of dementia with a high degree of accuracy. Tau PET became available in 2014. And in this image, we can see 4 separate people, 3 individuals who have normal cognition, and below their images, CN is that designation, and 1 person with AD dementia. And they have amyloid and tau PET scans. The top images, those are just amyloid scans, and the bottom images are the tau PET scans. And so what we can see is the tau trace accumulates in the bottom images, and so you can have a little bit of tau, but the cognition is still intact. But in the 4th image, you can see, I'm trying to put my arrow on the, it's shifted on the arrow, just on the entorhinal cortex. And on that pink area in the 4th image is where the hippocampus and the subiculum, and those are the areas involved with short-term memory. So the tau biomarkers are measured in cerebrospinal fluid and in blood. Now, tau has a normal function. It stabilizes microtubules inside the neurons in the brain. However, in Alzheimer's disease, this process of excessive phosphorylation, hyperphosphorylation, leads to the formation of these neurofibrillary tangles within the nerve cells. And these are the things Alzheimer originally saw, which he called tangles. And they cause the nerve cells to die. That's what the process we call neurodegeneration. And so phospho-tau is released into the cerebrospinal fluid. So with the progression of Alzheimer's disease, this phosphorylated tau is going to rise. The blood phospho-tau is also elevated in Alzheimer's disease, and CSF and blood phospho-tau consistently elevated in individuals with Alzheimer's disease changed compared to those who don't have AD changes. The biomarkers of interest are the p-tau 181, p-tau 217, and the p-tau 231. These are the most studied biomarkers to diagnose at present. In the future, there will likely be more. Now, immunotherapy is an approach which is being used in cancer, arthritis, osteoporosis. People who are on osteoporosis medications may know of a medication called Prolia or denosumab, and now we have immunotherapy for Alzheimer's disease. We understand antibodies as the body's natural defense against diseases, and so using passive immunization, so this is where we give intravenously an antibody, or alternatively, it can be given subcutaneously under the skin to try and remove amyloid from the brain. So active immunization is another line of approach that some groups have pursued, but I'm not going to be talking about the vaccine approaches to Alzheimer's disease, but they do undergo research studies. This shows amyloid being removed from the brain in a mouse experimental model. At autopsy, you can see on the mouse amyloid accumulating towards the end of its life, around 2 years, and you can also see mice treated where there has been antibody removed from the brain in figure B. In participants in a trial, the babenusamide trial in 2008 to 2010, given intravenous babenusamide. And in this slide, you can see 4 groups of images. In the top line are the 2 participants who are in the treatment arm, and in the bottom line, 2 participants who are in the placebo arm of the trial. And for each participant, there is a screening image at baseline and another at the end of the trial at 78 weeks. And you can see for participants A and B who had treatment, there's removal of amyloid from the brain, and for participants C and D in the placebo arm, there is gradual accumulation of amyloid in the brain when you repeat the PET image at week 78. Now, there is a side effect to removing amyloid in the brain in some people, which may occur. And the term that has been used is ARIA, amyloid-related imaging abnormality. And you can see these changes on an MRI scan. So what we're seeing here on we have ARIA E, which is the ARIA edema, and we have ARIA H, which is ARIA hemorrhage. If you look at the top left-hand image of an MRI scan, this is a screening. So this orientation of this image is from front to back, and you can see at the top of the screen is front, and the bottom of the image is the back. You can see in that first screening flare image, you can see the wriggly parts of the brain, the gyri and sulci. You can just make out at the front of the brain that you can see the demarcation where those folds occur in the brain. With the PET imaging next to it in the middle, there's a screening PIB scan. PIB stands for the Pittsburgh B compound, which was the first PET tracer. And you can see the red accumulation of amyloid in the brain. Then you move across to week 6, the flare image of the MRI. And now you can see where the arrows are pointing is there's some little puffy white spots and at the front. And you can also see that the wriggly parts of the brain are not as easily seen. And this is because there's brain swelling or edema. You can then look at week 19, and in those follow-up MRI scans, that the edema that was there, those white spots at the front, have gone away. And you can now delineate more clearly the wriggly parts of the brain, the gyri, and then the sulci between them. And you can see week 19 PIB scan, removal of amyloid because there's less red. And then the week 19, and this is a gradient echo MRI scan. So you can see this is a different image because the cerebrospinal fluid in the ventricles in this center part of the brain, instead of being black in this image, it's white. And then above that white, where the arrows are pointing, you can make out some black, which is where the microbleeds have occurred following the removal of the amyloid from the brain. So this is showing how we can see some of these side effects. Now, most people who have this edema and the hemorrhage have no symptoms at all. So that's an important point. Now, lecanemab is a monoclonal antibody. When we talk of a monoclonal antibody, if you see a molecule which at the end of the name of the molecule, it has MAB, that means monoclonal antibody. So denosumab that I gave earlier for osteoporosis is a monoclonal antibody. Lecanemab is one as well. And this image is showing 3 different forms of the amyloid proteins. So on the left, we've got 5 monomers, 5 individual molecules of amyloid. And then in the center, the toxic forms, the oligomers and the protofibrils. The oligomers is where you get a little clump of amyloid molecules. They're sticky molecules, they stick together, and the protofibrils and little chains. And these are still soluble. They're still in the bloodstream and then, or soluble within the brain. And then on the right side, you have the fibrils, which are the insoluble forms, and those are the ones that form the plaque. And so lecanemab targets mainly the toxic forms. It does remove some of the insoluble forms, but it doesn't really bind strongly at all to the monomers. So you can see the binding being strongest with those toxic forms of amyloid. So in the phase 3 trial of lecanemab, which was published in the New England Journal of Medicine, participants were ages 50 to 90. So they had some participants who were quite advanced in their years with symptoms of mild cognitive impairment or mild dementia. And they knew that they had Alzheimer's disease because there was evidence of that amyloid on the PET scan or the CSF. And the participants were randomly assigned either to treatment or to placebo in a 50-50 ratio. So that was blindly. They didn't get to choose which arm they were in. And then they were given the intravenous treatment every 2 weeks. And when you do a clinical trial, particularly at the phase 3 level, you want to have some measurements of what is the effect of the intervention. So we have what's called a primary outcome measure. This is always specified before the trial starts. You decide what it is we're going to measure. And in this case, they chose a change from baseline to 18 months, because it was an 18-month trial on the clinical dementia rating scale, sum of the boxes. They had secondary outcome measures, so it was the change over the 18-month trial on a activities of daily living scale. And they also had change in the Alzheimer's disease assessment scale, the ADAS-Cog14, similar to the one used in the earlier synergic trial that I mentioned, and then change in the amyloid burden on the PET imaging. So this is what the trial looked like, the data looked like published. This is not specifically from the New England Journal, but across the baseline, you can see from 0 to 18 months. You can see across the baseline in black the placebo numbers of participants, the lecanemab participant numbers. And you can see on the vertical axis from 0 down to 1.6 worsening. So you can see as you go down that scale on the vertical axis, a person is getting worse. So over time, you can see both lines are declining down to the right. So both groups, both the placebo and the treatment arm group. But the other thing to observe is that the slope of the decline of the green line, the lecanemab people, is not as steep as the placebo. So they are declining, but more slowly. And so you can calculate the slowing, which is 27% slowing over 18 months. And then if you look at the secondary outcome measures, this is the activities of daily living scale. And you can see the same pattern. It's the same 18-month trial. And there in this, the measurements across using an ADL scale. So a change from baseline, a declining number, they're getting worse. So the placebo worse, but the people in the treatment arm, 37% slowing in the treatment arm. And these two lines are diverging. They're going away from each other. So this shows that there's a slower decline in the treatment group on lecanemab. This is the same sort of pattern with the 26% slowing using just a straight cognitive measure, the ADSC cog 14. This is the PET imaging changes. So during the course of the trial, the 18 months, you can see that the participants had 4 PET scans. Now, there's not as many participants who have had PET scans because not all sites who participated in the trial had a positron emission tomography available. They didn't have a cyclotron. They didn't have this scans available. So this is why we've got smaller numbers. You can see, though, at the black line at the top that the placebo arm is creeping up gradually over the 18 months. So this is further accumulation of amyloid. But the green line you can see is dropping quite quickly down, showing that there's removal of amyloid from the brain. And this is even apparent and is statistically significant at 3 months. You can see that ring around the 3 months, and certainly at the end, it's dropped almost 60 centiloids. So the baseline on that centiloid scale out of 100 was about 80 for the participants, and it's a bit over 80 for the participants at the end of the people on the placebo arm. At the end of the trial, they were up around 82, but the people on average on the treatment arm, they were certainly less than 30. So it was almost a 60-point drop on the centiloid scale. Now, we mentioned hemorrhages, microhemorrhages. It's important to understand that microhemorrhages are a natural phenomenon in some people. So on this graph, you can see different groups of people, the general population, people with mild cognitive impairment, people with Alzheimer's disease, ischemic stroke or hemorrhagic stroke. And on the vertical axis at the left, you can see the prevalence, how common it is for people to have brain microhemorrhages. So 5% of the population have brain microhemorrhages. People with mild cognitive impairment and Alzheimer's disease have more commonly have microhemorrhages. And there are reasons for that. And so you can see people with Alzheimer's disease, about 22% all have brain microhemorrhages. And these are detected on MRI scans. And I showed you earlier the particular sequences, the gradient echo, also this a different sequence called the susceptibility weighted images on an MRI scan, not a CAT scan or a PET scan, but an MRI scan can show these changes of these microbleeds. And for the clinical trials, people who had more than 4 microbleeds at baseline were not allowed to participate in the trial. And that, I think, is probably going to be an indication with the treatments. Once we anticipate they'll be approved, once they're approved, we think that there will be a label on it saying that people need to have a baseline MRI scan and that they shouldn't have more than 4 microbleeds at beginning, because they'll be at greater risk of developing hemorrhage if they are then going to have treatment. So the most common adverse events with the lecanemab trial, you can see events more than 5%, headache, 11% versus 8% in the placebo arm. The rest of them are fairly evenly balanced. The adverse interests of special interest are the infusion-related reactions. So these are when you give an infusion, sometimes there's a bit of a reaction. In placebo, 7.4% of the placebo arm had a reaction, and 26% of the lecanemab arm had a reaction initially to the infusion. Area E, you can see 1.7 and 12.6 in the lecanemab arm, and area H, a further difference between the two groups. Isolated area H, the spontaneous microhemorrhages, it was balanced. So people who just had spontaneous hemorrhage without any area E, no edema associated with the hemorrhage, so just had microhemorrhages alone. This is common both in the placebo and the lecanemab arm. So the summary data was that it was generally well tolerated with the side effects that we spoke of. The area E was more common within the first 3 months. It was resolved usually within 4 months. And I said earlier there was no imbalance between them for the isolated area H microhemorrhages. Of the other biomarkers, the tau biomarkers measured in both cerebrospinal fluid on the left and the plasma p-tau 181 on the right. So p-tau 181 was the biomarker chosen for this particular trial. And you can see the p-tau rising in the black or placebo arm. So it's getting worse than the placebo arm, because we said phospho-tau rises with progression of Alzheimer's disease. So you can see the biomarker in the treatment arm declining, which is what you would expect to see a biomarker do if you're actually modifying the disease. And the same is happening in the blood on the right. This is some of the images from the trial of donanemab, which is the second intravenous antibody, which has been part of a randomized controlled trial. And in this trial, you can again see the same pattern. Again, was an 18-month trial, 76 weeks. You can see in black the placebo numbers and the donanemab numbers. Not as large a trial, because this was a phase 2/3 trial, and they used a different primary outcome measure. They used the iDRAS on the vertical axis, going from 0 down to -1, and this is a change on the iDRAS. So going down is worsening, and so you can see again the same pattern with both lines declining, the placebo declining more, than the treatment arm, and a widening gap between those two arms. So calculating a 35% slowing using this measure. And then on the next one, the clinical dementia rating scale, which was the primary outcome measure on the lecanemab trial, they chose with this trial to use a cognitive measure as the primary outcome measure. So this is the clinical dementia trial, clinical dementia rating scale, some of the boxes, and you're seeing the same patterns we saw with lecanemab. And again, when you look at function, the IDL scale, you can see the decline with the placebo arm more than the decline in the treatment arm with donanemab. And with the ADAS-Cog13, a different cognitive measure than the IDRAS, also a decline and a widening on the treatment arm, a slower progression of 32% difference. For now, trials for individuals with normal cognition, and lecanemab is being used with this particular trial called the AHEAD trial, and it's got 4 trial sites in Canada, 75 globally. In London, we are one of those 4 trial sites. Dr. Jaspreet Bangu, geriatrician colleague, is the lead investigator for that. And the A3 trial is a preclinical Alzheimer's disease, intermediate A-beta. So these people have 20 to 40 centiloids on the amyloid scale, so not as much as in the lecanemab trial in people with mild cognitive impairment and Alzheimer's disease. And then there's an A4-5 arm of it, and these people, they have elevated amyloid on the PET scan, so they have more than 40 centiloids. But these people have normal cognition, and if they're between ages 55 to 64, they must have one other risk factor. Now, the interesting thing about this trial is they're using blood biomarkers. So the screening goes through a stepped process. So a person will have a blood test first, and the blood test is either positive or negative, and they're measuring P217, one of the blood biomarkers I spoke of earlier, the phosphatide one. And if it's negative, they don't go any further. But if it's positive, it predicts that that person will likely have a positive amyloid PET scan. And then if the PET scan is positive, normal cognition, they can then participate in this trial. It's a 4-year trial. The people who have less amyloid have monthly infusions. The people who have more amyloid up until week 94, they have every 2-week infusions, then monthly. And because people have normal cognition, you have to use different endpoints. So the primary endpoint in the A3 trial is the clearance of amyloid, because they know the lecanemab can remove amyloid, so you can measure that. And that is a measure of modifying the disease. And then the A4-5 trial uses an instrument called the preclinical Alzheimer's cognitive composite. It has to be something that's very sensitive, that's going to measure change in people who don't have any cognitive impairment. This is another trial. Dr. Manuel Monteiro Dasso, again at Parkwood Institute, and a colleague is embarking on a synergic 2 trial. The participants, again, the similar age range, 60 to 85, they must have mild cognitive impairment described there. They must have two or more dementia risk factors, so at risk of getting progression to dementia. There's a screening process, but the 2 interventions are shown there. So it's a larger trial. Instead of 177 participants, they're targeting 550, and they're recruiting participants for this trial. So people that are interested in participating in this sort of trial, which is an online personalized intervention, multi-domain, and they will have coaching sessions every 2 weeks, targeting physical activity, cognition, diet, sleep, vascular risk factors, versus people who are randomized to an education intervention using education modules on all of those things. And this trial is twice as long as the synergic one. This is now a 12-month trial. We also have new observational studies. So our group, the Cognitive Clinical Trials Group, has been involved with the ADNI study, the Alzheimer's Disease Neuroimaging Initiative, since its inception and initiation in 2006. And this study has been very instrumental in advancing our understanding of our clinical trials that we are doing now. Having measured people with mild, who have normal cognition, people with mild impairment, and people with Alzheimer's disease, and doing regular neuroimaging, blood biomarkers, CSF and PET imaging to understand what is the natural course of the disease, what's the natural course of these PET biomarkers. So that's where all of that, a lot of that information has come from, along with other observational studies around the world. ABLE in Australia, for instance, one, and there's other ones in Europe. But this has really informed this whole process. And what they're doing with this particular study, they have an underrepresented group that they want to recruit people from racialized communities. With our own comprehensive assessment of neurodegeneration and dementia study, COMPASS ND, this is the Canadian study equivalent to ADNI, and this is being led by our Cognitive Clinical Trials group at Parkwood Institute. We're the lead site for this national study. And Sarah Best, who's on as our research manager for our group, is certainly able to speak to any of these trials if you have specific questions about them as it joined this webinar. But this time we're going to target people and try and attract people who have up to grade 12 education plus life experience, because again, this is a group that's underrepresented, and we want to have these studies to be representative of the whole Canadian population as much as it can be. So trying to make sure that underrepresented groups able to participate and generalize the findings. This is a study we're doing through our Aging Brain and Memory Clinic, and Dr. Brangu, Sarah Best, Kayla Vanderploeg, and I are organizing this trial. It's going through the review process, through the ethics review. Kayla and Sarah helping with the submissions and responses to any questions, and that's almost completed. We'll be measuring biomarkers, cerebrospinal fluid, and this has been done by Dr. Adrian Budrum, who's a neurologist here in London at London North Sciences. You'll be able to measure CSF. Previously, we've always had to send CSF to Vancouver, so now we actually have it available in London. Never had it before. PET scans with Dr. Ting Lee at the Grosvenor site with St. Joe's. And we're also going to do the blood biomarkers, the Precivity AD test through C2N, which we'll contract with through the States. And then you can see a schema there for participants who already who have been referred by a family physician, who may be on the waiting list to be seen in the Asian Brain and Memory Clinic. Right now, we're booking new referral people to be seen in the Asian Brain and Memory Clinic in June of 2025. So this is an 18-month period, but people may have to wait. And so what we're hoping is that through this type of biomarker study, we may be able to learn more about how do we manage biomarkers and how does it inform who might be eligible for treatments when they eventually become available. So through this process, people who are on the waiting list will be invited to participate in the study. They may decline and just say, I'll wait for my appointment. Or they may say, well, I'd be interested in getting these biomarkers, which will be available, and the results will be completed. They'll have a PET scan, the blood biomarker, the lumbar puncture, cerebrospinal fluid, and then at the time of their appointment when they come, those results will be available. And then there'll be surveys to see what does this mean to the participant, the study partner, and what does it mean from the clinician's perspective, and being able to make a firm diagnosis of Alzheimer's disease. Instead of it being probable Alzheimer's disease, now we'll have a way to know precisely what is the cause. Is Alzheimer's disease causing this cognitive decline? We are in an era of disease-modifying treatments. They've been approved in the States. They're starting to be used there. Lecanemab and donanemab have both been submitted to Health Canada, and we're waiting for decisions on those compounds. We know that we will be able to diagnose with certainty that a person actually has the underlying Alzheimer's disease as the cause of their mild cognitive impairment or their subjective cognitive decline, or even detecting it in people who have a family history but who are cognitively normal but are worried about the possibility of developing Alzheimer's disease. And that might be some caregivers who are now looking after individuals family members who may have had the disease and progressive dementia for 10 years or more, or maybe in their 80s, but their caregivers may be in their 50s and 60s who may be interested, saying, well, am I at risk? Could I learn if I am at risk? And by getting a blood test, they could actually find that out. So this advances in the technology of being able to measure these biomarkers in the blood very precisely has been really important. We're using it in clinical trials now to actually determine who might participate. We're going to have, before we have it in laboratories here in London, we're going to have reference materials, normal values, all of these have to be approved. So that's a process that will need to take not months, but maybe 2 or 3 years. We can anticipate these things. We still anticipate most patients will see their primary care providers with their memory concerns. We recognize there's limited specialist memory clinics to confirm diagnosis. We need to see how can we be more efficient. Blood biomarker is going to be something that's actually going to help that. And this is a schema showing how this might apply in family practice. You have 3 different groups of people here who may have low probability, medium probability, or high probability based on a blood test, and it might have implications. No need to worry, maybe further testing, or maybe initiate treatments early on the disease. And you can see we're wanting to go much earlier before a person even has symptoms, is what we hope, that this will actually delay considerably progression of the disease. We don't know that yet, but the AHEAD study is something that's really going to tell us whether this is the case by removing amyloid early on before it accumulates and before the tau proteins start to hyperphosphorylate and cause the death of the nerve cells while it's slow disease. There's obviously the caution. We need to get the balance right between the risks of the side effects, which I mentioned earlier, and the potential benefit. And there needs to be education, all of those questions there, and many more that need to be. We need people with lived experience participating in these decisions. We want to be able to be sure that cost is not going to be a barrier, and that there's going to be equitable access to approved therapy. I know the Alzheimer's Society is very strong advocates for all of these things and making representations to Health Canada and eventually, presumably, provincial jurisdictions who would be funding these treatments. So to finish, we want to thank the participants and their study partners who have continued to participate in our observational studies and the controlled trials to be able to advance cognitive impairment research, and an acknowledgement again to our study partners. And this is during COVID times. Dr. Jenny Wells, myself, and Dr. Jaspreet Vangu, Jennifer Elizabeth Finger, and Stephen Pasternak, our colleagues in cognitive neurology, all of our team, research coordinators, our fearless leader, Sarah Best, and our nurses and our neuropsychologist, Dr. Jennifer Fogarty, and our other collaborators. So thank you very much for your attention.
Great. Thank you so much, Dr. Borrie. Okay, so wow, thank you for sharing your knowledge. It was a lot of really new and engaging material. There's so much happening. It's really exciting. So thank you for sharing that with us and your insights. So to our attendees, I see we already have a couple of questions and hopefully more will come in. You probably have lots of thoughts and questions after hearing from Dr. Borrie. We do have about a half an hour actually, which is wonderful, available for questions. And again, we will do our best to get to as many as we can. And a friendly reminder to please enter all questions in the Q&A box, not the chat box. And that'll make it easier for us to keep track of them. And also, again, keep an eye on the questions that are coming in. And if you see a question that you would like the answer to as well, you can use the thumbs up to identify that. So just to get us started, Dr. Borrie, you did allude to this, but thinking about timelines, ability to sort of scale up some of these things. So just even getting the access for primary care to be able to do the blood tests identifying the biomarkers. Where are we at with that currently?
Well, thank you for that question. And you're right, it is an issue of scale, and we're going to need to start. I think it's going to be a matter of experience. And I think initially we had the experience through our clinical trials with our specialist groups. And I think starting there is going to be where it will be initiated with these treatments. Now, we need to understand that the lecanemab, donanemab, which are the leading compounds, haven't been approved yet. We're waiting to see. Maybe we might get indication by June, and donanemab later on in the year. These are our best guesses as when we might have decisions on these. We know they've been approved on the States, so we have to wait and see what happens. And I don't want to second guess what the decision would be of Health Canada, but there's a lot of interest in these compounds. And I think there's also things that we've alluded to is, we need to have centers that are going to be able to administer, to be able to assess participants to see that they're appropriate. It's very important that the people that get the treatments are the appropriate people, that they have the underlying Alzheimer's disease there, they have the PET. For now, it has to be PET or CSF blood biomarkers. So we will hopefully see that lumbar puncture will become, as it is in some European countries, certainly in the Netherlands, in Denmark, CSF is part of the initial clinical workup. And we would see that people would accept that this is part of the test that you would have to determine you have Alzheimer's disease. Our hope eventually is that these blood biomarkers will be validated against CSF and against the PET imaging, and that they will be accepted as equivalent. They're not there yet, and we don't have those blood biomarkers available. We do now have the CSF biomarkers, and in London we will be able to have that. So that's something that we're anticipating. The other thing I mentioned was about MRI scan. We need to make sure the appropriate people are offered treatment. So they can't have more than 4 microbleeds. So we need to make sure that they have the correct MRI images, the type of scans. So they have to be MRI scans, and they have to be susceptibility weighted images. So they have to be the correct sequences to actually show whether or not there's microbleeds, because you don't want to be offering a treatment to a person which may put them at risk. And so that's part of that risk benefit. And then having infusion centers. And I know Sarah Best has been talking with not only our hospital people, but also the pharmaceutical companies, just to try and get an idea of where would this actually start. But my sense is that this is going to start slowly, certainly in the first year, but it's going to be cautious. It's not going to be a huge rush, but I think there is a lot of people that are interested.
Definitely, yes. No, and so I think we'll jump in. We're starting to see some great questions coming up. And the first one is, if the intervention removes amyloid, is this removal permanent, or does the amyloid come back?
Thank you for that. So amyloid, as you can see in the placebo group, gradually increased. So over the 18 months trial, the placebo arm and the lecanemab trial, the average amount of amyloid went from 80 centiloids up to 82 centiloids. So the disease process continues on. If we remove the amyloid, does it come back? We have to follow people over a longer period of time to know whether it comes back. And so one of the decisions is, once you give a person a treatment, how long do you give the treatment for? And when do you stop giving the treatment? At what point have they removed the amyloid? Now, they do continue to decline. We saw that they will continue to decline. And the other process that is occurring is the hyperphosphorylation of tau. And it's the hyperphosphorylation of tau that's killing the nerve cells. And there is some evidence that when you look at the level of the nerve cells, that this hyperphosphorylated tau spreads almost like a prion-like disease. It isn't a prion disease, but it spreads one cell almost like affecting the next cell next to it and that sort of thing. It spreads in that sort of way. So this is why there is the thinking that we should stop the amyloid from accumulating first before it then triggers. It somehow seems to trigger the tau protein's hyperphosphorylation. There seems to be a connection between amyloid deposition and the tau protein. You don't get Alzheimer's disease if you don't have the amyloid, but the thing that causes the cognitive impairment is the hyperphosphorylation of tau. So that process may be on the roll, it might be on the way, and by just removing amyloid may be starting to slow that process, but it may not alter it. So there are other treatment trials that are looking at trying to see how do we reduce the progression of the tau imaging, of the tau hyperphosphorylation. Are the treatments that could actually do this? We have some trials now that are actually looking at that because that is what's causing the cognitive impairment. So I think we can remove the amyloid. Will it come back? It may come back. Can we remove it again? We can remove it again. But is that the only thing we have to be paying attention to? We need to also pay attention to what's happening with the hyperphosphorylation of tau. And that's maybe part of why people continue to progress, but at a slower rate.
Okay, thank you. So this might be a question for Sarah about
Good.
how to sign up for the trials.
Sarah can speak to that for sure.
Yeah, right. So on the last slide, I'm not sure if the slides will be shared. I think they'll be posted online. There's an email that you can reach out to, and we'd be happy to get back in touch with you as soon as possible. It's memory@sjhc.london.on.ca, but we can share that. Actually, I'll put it in the chat.
Oh, perfect.
And then there's a phone number, and we hopefully are anticipating some calls after this presentation. Be happy to discuss all the different trials that we have to offer at Parkwood.
Wonderful, thank you. Okay, so yes, if you can put that in the chat, that would be fabulous, Sarah. Thank you. Yes, and again, this is being recorded, so once the recording is available, you'll be able to see kind of everything together. And I might just clarify this. Another question about the presence of amyloid guarantee Alzheimer's disease, and I think you've spoken that that's a sign of Alzheimer's disease, that amyloid has to be there, but I guess maybe if the amyloid maybe causes somebody to develop the symptoms, perhaps.
So let me clarify that, because that's an excellent point. So someone who has a family history, so someone who may be in their 50s or 60s or 70s, where there were other family members, parents or grandparents, who developed symptoms in their 50s, 60s, 70s, then those people may be concerned, am I at risk of developing Alzheimer's disease? So they may be accumulating amyloid in their brain and they wouldn't even know it because it's occurring for 20 years before they actually start to get any cognitive symptoms. So they could have a blood test. It can be either positive or negative. If it's negative, then for the studies that we're doing, like the AHEAD study, that person would not be eligible to go any further in the screening process. If the test is positive, confirming the presence that there is amyloid accumulating, then they could have or that there is an Alzheimer-like process occurring. They could then have the PET scan and confirm if it's positive or negative, and then enter the trial. And this is how we can use biomarkers to help people know whether or not there really isn't any other way I can think of knowing. Now, a person who has mild cognitive impairment and who has a positive amyloid PET scan or positive on a CSF, which is probably going to be easier for us to actually offer people, because I think the PET scans are expensive. They're, for clinical trials, they're about $5,000 a pop. They're not clinically available, and they're only involved in the research study. But I think CSF is going to be something that we will be able to offer more easily for persons. So if someone has mild cognitive impairment, has positive CSF biomarker, or positive amyloid biomarker, and they have MCI, they are at much greater risk than someone else who has a negative PET scan or a negative biomarker of developing Alzheimer's disease within the next few years. The precise time is difficult to predict. But in their 50s or 60s, they may want to know that.
Okay, perfect. So next question is a little bit different, going back to something you spoke of earlier about the comparison trials using vitamin D versus placebo
Yes.
To prevent cognitive decline. So was there a benefit of taking 10,000 international units of vitamin D 3 times a week?
Now, the short answer is no. Which was interesting because vitamin D has been certainly is good for bones, for bone health. It's very good for bone health. So we see people who are osteopenic or who have fractured and are osteoporotic, vitamin D levels we can measure, and their levels, if they're less than 75, they need to be on regular doses. 2,000 units a day would be often a sufficient usual sort of dose. But there was some thinking that maybe high-dose vitamin D might have a positive effect in combination with the physical exercise and maybe with cognition. But it didn't show any positive benefit. So you can see that the Synergic 2 trial, so what we've learned from that, one of the arms in that, or one of the interventions in that Synergic 2 trial is not going to be with vitamin D. Vitamin D won't even be in there. People should be on vitamin D for other health reasons, but not because it's going to prevent cognitive decline.
Okay, all right, thank you. So a question here about focused ultrasound. So is it effective and is it available in Canada? And then a separate question, so maybe we'll address the first one. There's sort of a different, completely different question. So let's talk about focused ultrasound first.
So I'm assuming when a person means focused ultrasound, this is focused ultrasound to the brain. There are some very innovative imaging techniques, some of them using ultrasound, some of them using infrared processes. There are even innovative ones looking at the eye, looking at the retina, measuring amyloid there. These are not techniques that we're particularly using or that we're researching, and so I can't comment on them, but they're certainly not in the clinical domain at this point for diagnosing Alzheimer's disease. But I think that there are many, many different strategies, some of which we're not involved with at all, and I don't have a lot of information. So I couldn't say right now, but as a biomarker, does it have potential in the future? Maybe, depending on what the researchers find. But I can't speak to that as a mainstream biomarker. But there's certainly some very innovative approaches that people are pursuing.
Perfect, thank you. And the second question this person asked, and I think you maybe addressed this because I think it might depend on the type of trial. So what stage in Alzheimer's disease can a person enter the trial?
Well, I think maybe I'll defer to Sarah, maybe could answer that, because I think there's a number of different observational studies and intervention studies, but she certainly has the perspective on that.
Yeah, so anyone who's interested, regardless of what stage you may be at, I think please reach out to us. There's different studies that are open for participation at any given time. And we can reach out, but generally we do try to have a study for everyone who's interested in participating. So we do our best to get everyone involved.
And I would qualify that in the sense of there will be, we certainly do try to do that. There are, as you see with the trials, there are certain age cutoffs. So one would have to be, for some trials, above 50 or above 55 or 60, depending on that sort of thing. For the observational studies, for the Compass ND, people that have up to grade 12 education plus life experience, those particularly people, we have something we can offer them for an observational study. I think if a person has strokes as a cause of disease. So if they've had strokes as a cause, so they've got a vascular cognitive impairment, that's less likely that we would have something that we could offer them. And if someone had moderate or severe dementia, those particular trials, our particular group doesn't have. Some groups have, if there are behavioral medications or interventions, there may be some studies for people where there's behavioral problems for severe dementia. We don't have trials for people who are in long-term care facilities. That would be right at the moment, we don't have anything for people who are in long-term care.
So just on that note, to both of you, because there's a question a little bit further down that might be connected to this. So you mentioned life experience. This person's just lived experience. It might be the same thing. If I've got it wrong, please enter the question again. So what does the life experience represent?
We acknowledge that even though we have a formalized education system, and one way of characterizing people's education attainment, formal educational attainment, through certification, through high school or through college or through university with different levels of attainment. However, there are many, many people who have, for whatever reason, have had limited opportunities when they were younger, and or they may have been immigrated to Canada and not had the same opportunities in their countries of origin, and yet have a great deal of experience through their own lived experience, whether that's whatever the type of work they've been involved with, and have attained a very high level of skill and proficiency in a different thing. These are different types of education, and everyone participating in the trial, in observational studies, we want to record what has been their experience, because we want to know. There is this idea that educational attainment is important for protecting as a protective effect and building resilient networks. But there may be different ways of actually building those resilient networks through the type of work that people may have been doing during their careers. So we don't want to be excluding that possibility. So we have questionnaires that tries to capture that type of lived experience that people have. And people have very, very rich experiences, which may in some way provide protective factors against developing dementia.
Right. I guess that idea that we're all lifelong learners, right? We might be learning from
we absolutely are, and we don't want to artificially, but when we ask people about their level of education, the first thing people think of is, well, how much high school did you have? How much elementary school did you have? And this sort of thing. And yet we see people who have up to grade 12 within that group who have been very successful in their various careers.
Wonderful. Thank you. That's great. I think you've addressed this. The next question was talking about perhaps a mixed dementia with vascular and Alzheimer's. And I think you may have already addressed that in terms of accessing the trials.
I think it's more difficult if a person's cause of dementia is due to mixed vascular causes. So they may have vascular risk factors that I mentioned earlier, the smoking, the high blood pressure, diabetes, hyperlipidemia, atrial fibrillation. They may have had clinical strokes during some of their course of their health history, and they may have changes on the MRI, which shows widespread white matter changes. I didn't even talk about white matter changes. This is something different, but we have a Fazika scale, 0 to 3. If it's 3 out of 3, those people unfortunately cannot participate in the trials, because I think particularly the intervention ones, now they can participate in observational studies. If they have vascular MCI, they can certainly participate in an observational study. And we have for the particularly if they have the education level up to grade 12, those people can participate in something. But with the intervention trials, it's the risk of hemorrhage would be concerning.
Right. So there's a question here, and it's a great one. I know early on you spoke about other types of dementia, one being Lewy body dementia.
Yes.
And so just in terms of what, if anything, applies to Lewy body dementia, and maybe just to add to that, what sort of research is happening in that realm to support people who are living with that type of dementia?
Well, thank you for that question. That's an excellent point. And Lewy body dementia can be primary Lewy body dementia, Lewy body disease, so that the typical presentation, visual hallucinations early on, Parkinsonism, and fluctuations in levels of consciousness are some of the typical symptoms seen with used for the diagnosis. But the new thing that's happening with Lewy body disease is now that there are imaging approaches being developed in Europe, and the DAT scan to measure dopamine reserves in the brain, particularly in people with Parkinson's disease and Lewy body disease. And there are now blood tests. So just as we've talked about blood biomarkers for Alzheimer's disease, there are now blood tests being developed in research for Lewy body disease. This is measuring alpha-synuclein. So in Lewy body disease, it's a different protein abnormality. It's alpha-synuclein. And we also, I mentioned primary Lewy body disease, but we also know that about 30% of people with Alzheimer's disease may also have Lewy body disease. So that may be another disease that is causing that progressive decline in the people. And we certainly have seen in people with Alzheimer's disease who have participated in Alzheimer's disease trials who have actually progressed very rapidly and passed and then agreed to have an examination of the brain found to have Lewy body as a second abnormal pathology. So I think we will see, it's a bit behind, but all of these neurodegenerative diseases, frontotemporal degeneration with misfolded proteins causing that type of dementia, we anticipate that we will see new blood tests, biomarkers for all of these different types of neurodegeneration, and potentially new trials to actually be able to slow or hopefully eventually arrest these diseases. In London right now, we don't see a lot of people with Lewy body disease for whatever reason, with the exception that Dr. Pasternak, one of our colleagues, has been studying Ambroxol in a drug, it's a cough syrup. It's been repurposed as a drug. He has studied it with some promising findings of people with Parkinson's dementia. But if he wants to progress further, there may be exploring into the area of Lewy body disease. There's also our colleague in Edmonton, Dr. Richard Comiccioli, Dr. Tony Lang in Toronto, who are very interested in pursuing Parkinson's disease and Lewy body disease. So and they're participating in the Compass ND. Dr. Richard Comiccioli is a leader in that area in Lewy body. So there are things happening in Canada. Nothing right at the moment in London, but it's certainly a very promising area of research.
Great, thank you. Just looking through to see if we have some common questions. Somebody did ask about, I think similarly with frontal temporal, but I think you've sort of touched on that. So I think we'll move forward. Okay, so just try to get maybe one or two more questions. So there was a question about if there are studies considering kind of non-pharma approaches to treating Alzheimer's, and you mentioned some a little bit earlier, but thinking about what might be happening in that realm.
Well, in London, the non-pharma trials, and we certainly would encourage people, if they're interested, they call the line and we can refer them on to Dr. Montero Dasso's group, looking at that Synergic 2 trial. This is in people with mild cognitive impairment, and it can be either amnestic or the vascular type. So due to Alzheimer's or vascular, they will do blood biomarkers. As part of that research effort, they will draw blood for that to see what do all of these interventions do to the blood biomarkers, because that's what we really would like to understand. If you have non-drug interventions, what do the non-drug interventions do to the blood biomarkers? Do they cause p-tau 217 to go down when you exercise and that sort of thing? We want to understand that. So now we have these blood biomarkers, we can understand those types of interventions. But there are that particular trial where they're going to be recruiting people, and they'll have the at-home interventions, either the exercise and all of the diet and all of the coaching. So they're actually having someone calling and following up with them. One of the things I would love to have in my clinic is someone that would be able to coach people, because we tell them all of these interventions, so they say, that's great, sounds good, and then they walk out the door and they come back a year later. And some of them have been good about intervening, starting the interventions, and some sort of not so good, and some have forgotten about them, but that's why they were there in the first place. So
yeah, so great. Well, there is a question about hormone replacement therapy in women, menopausal women, and I feel like that's probably something we want to explore maybe as an actual whole other webinar. It's probably a pretty big topic. I am very mindful of the time. Do you have like a quick comment you can make on that, Dr. Borrie?
It's actually a really important question. It's an important area to explore. There has been research through the nurses study in the States, where they did look at hormone replacement in postmenopausal women, and certainly for some of the reasons that they were prescribing the estrogen, it was beneficial. But beyond 5 years, it increased the risk of vascular dementia, and this was a study from the early 2000s. But I think that there are researchers in Canada. Dr. Mary Tierney was one of the leaders in hormone research. I believe she's retired now, but there are others who are pursuing this as a research, understanding what is the importance, and is the hormone differences, the sex gender differences in male female sex, is the hormone differences between these, is that important in understanding? We suspect it is, in why women may be more likely to develop dementia. There are some straightforward reasons that maybe they live longer and they're more at risk, but there are other reasons as well. And often this may be on the basis of hormones. So this is an area of research, and part of the Canadian collaboration in neurodegeneration. Gillian Einstein is the lead for the whole sex and gender initiative, and is always pursuing these areas to see differences.
Great. And Sarah, you wanted to make an additional comment about biomarkers?
Yeah, I just wanted, I know we're running out of time, and I'm just scanning some of the questions, and there's a couple of questions about biomarkers, including cost and insurance implications. And just right now, that we're just not quite there yet. So the biomarkers are definitely still in the research phase. And right now, when Dr. Borrie in earlier slides was talking about the study and us looking at blood biomarkers and PET and CSF, it's really a feasibility study to figure out how we can actually get this, how we can actually make this more widely available for everyone else. So stay tuned. Right now, we're only offering this through research, and then we're going to use those results to try to actually make it more available to everybody. And I think that was Dr. Borrie's comment that we're probably looking as a matter of years versus months. So it's not, going to be available in a couple months. Probably stay tuned in the next couple of years and see where this goes. So those are really good questions, and we're just not quite there yet with the biomarkers.
Thanks, Sarah. So just to wrap up, really, Dr. Borrie and Sarah, thank you so much for making time this evening to provide these updates and all of this information. And we saw just how much discussion and curiosity this created amongst our attendees. So we thank all of you for attending. And just a note, our next webinar will be February 28th, and we will focus on interactions with fire services. So as part of our Living Safely with Dementia in the Community. And just a quick thing, when you leave, you will get a little notification pop up about an evaluation. So we're happy to have folks do that evaluation so we know how things are going, and also some topics for future webinars. So everyone, hope you have a great evening, and thank you all again for attending tonight and learning with us.
And Sarah, and I would like to, if I could, Susan, if I could thank you for hosting us. Thank you very much for doing the work that you do at the Alzheimer Society. Your support was Sarah Sweeney there at the Alzheimer Society. And I want to also thank again Sarah for participating, Sarah Best, and Shelley Crosby on my end, actually hopping on the technical side to make everything, it's always a relief to make sure that things go without any hitches. So thank you everyone for that.
Great, thanks again. And the recording will be available as soon as possible, and we'll make sure that people know when that's available on our website. So have a good night, everyone.